Well, welcome to episode 2 on the modes of ventilation. I hope you saw episode 1. If not, you may want to go back and see it. Hey, the first episode's all about building characters and plots. So if you don't understand the characters and plots, you might get confused. So go see episode 1. Now, one of the most common questions that gets asked when we teach mechanical ventilation, the modes of ventilation, is what is the most comfortable mode of ventilation? The answer to that question, none of them are the most comfortable. And all of them are the most comfortable. Well, what do we mean by that? That's kind of confusing. Well, one of my favorite answers to about anything related to the patient is it's patient specific. And that is actually true. Just about everything we do, the patients can react differently than some other patient. And as you're going to learn later, as we talk about the modes, it would seem that supported modes like pressure support and volume support would be more comfortable for the patients, and most of the times that's the case. But I've had plenty of patients who were not comfortable with those modes, and they did better on controlled modes of ventilation. There's no rhyme or reason to it. So oftentimes we have to try several different modes to see how the patient's going to react. Now the other thing to keep in mind is we're negative pressure breathers, and we use positive pressure ventilation. So we're completely reversing the way we breathe anyway. And the last thing I want you to keep in mind and think about is your patient. These patients are sick and are injured. They're scared, and you've got them tied down in bed, heavily restrained. They wake up. They may not even remember where they're at or how they got there. If that was from an accident, last thing they knew, they're driving down the interstate. Now they wake up in a scary setting. They got a tube shoved down their throat. They can't speak. They can't move because they're restrained and they're scared. And what's the natural reaction? They freak out. I would. I'm very claustrophobic. And then what do? With all the patience and empathy in the world, we stand over the bed and shout at them, hey, just relax. Let the machine breathe for you. How can they relax like this? I think we need to remember to have a little empathy on our ventilated patients. Now, without further ado, because he went through one full episode and part of this one, we're finally going to talk about our first mode of ventilation, that being controlled mechanical ventilation, or CMV. Okay, true controlled ventilation, it's not used very much anymore, if at all, so I'm not going to spend a lot of time on this. In true controlled mechanical ventilation, what you're going to do is you're going to set a respiratory rate. And that is the rate the patient's going to get. How many times or how many breaths they're going to get per minute. And if the patient makes an inspiratory effort, the machine's basically going to lock them out and not allow them to do that. They cannot initiate their own breath. This is very important to understand because when this happens, the patient's going to start to fight the ventilator. Thus, heavy sedation and in some cases even paralytics might just be necessary to get the patient to rest comfortably on this mode. Therefore, it really is only appropriate for certain patients, patients who are making no effort at all. Perhaps maybe a patient with a high-level C fracture causing paralysis. They might do good in this, but for the most case, there's not a lot of need for this mode of ventilation anymore. And since we mentioned it, let's talk about a patient fighting the vent. That's known as ventilator asynchrony. Some people say dyssynchrony, some say asynchrony, assist, I don't know, whichever one you want to use, okay? They're basically the same things. We want to keep stuff in mind when it comes to vent asynchrony. When a patient is fighting the ventilator, their body is going to produce more CO2. That's just how our bodies work. The higher our activity level, the more CO2 is produced. Also, the harder our bodies are working, the more oxygen it consumes. Now, in a healthy person, that's typically just not a problem. Our bodies can compensate just fine. But the sicker your patient is, the less apt their body is going to be able to adapt to compensate for these issues. And this is why it's imperative that we do our best to eliminate vent asynchrony. And again, as we've noted before, the less we try to control the ventilator, the more we let the patient take control, typically less asynchrony is going to happen. So in this mode, obviously we're controlling everything. So we're going to have a lot of ventilator asynchrony going on. Now the next classification for modes of ventilation will be your assist control modes. Okay, assist control modes are a little better when it comes to combating the vent asynchrony. Really, the only difference between CMV that we just talked about and assist control is under assist control, if the patient makes a spontaneous effort to take a breath, then what the machine is going to do is it's going to allow them to get that extra breath. So you may have a set rate of 12, but the actual respiratory rate might be 15 or 20 because the patient's breathing above that set rate and the machine's going to let them. So you can imagine it's going to be a lot more comfortable for the patient, right? Because now they can actually take some sort of control ventilation into their own hands. Now, the breath is still controlled in that what's going to happen is we're going to deliver a set pressure or volume for every extra breath the patient takes. It's going to be the same every single time. So we're still controlling how much air or pressure the lungs are going to get. We'll talk about that more as we go along. But how does this work? Basically, I'm glad you asked that. How does this work? Basically what happens, there's some settings in the ventilator that we're going to set. And what the machine's going to do, if it senses a certain flow or pressure change coming from the patient, based on that flow or pressure, it's going to know it needs to deliver a breath. It realizes the patient's trying to take a spontaneous breath and it's going to deliver it accordingly. So that's kind of how it works. It's like magic, right? So when it senses it, it gives that extra breath. There's basically 3 different modes that exist under the assist control category. That's volume control, pressure control, and volume guarantee, also known as pressure regulated volume control, or PRVC. And again, depending on what ventilator you're using, you might see some of these modes being called something different on a different machine, but they basically work the same. All right, we talked earlier about the nomenclature and the names. Basically, in these control modes, the ventilator is going to deliver either a preset pressure or a preset tidal volume to your patient, regardless of the inspiratory effort. Now, anytime you're getting ready to try a different mode of ventilation or change mode of ventilation, there's always things we have to consider. Of course, number one always is the patient, and we want to consider changing a mode if we think that that mode is going to make them more comfortable and create less asynchrony. And some of this is, of course, repetition, repetitive. It says stuff on the top that we've talked about, because we know if we eliminate asynchrony, then we're going to eliminate the increased O2 consumption, CO2 production. So we always want to consider these things. And then when we switch them, if we decide, yes, I want to do assist control ventilation, we switch to one of these modes, then we have to assess after we switched to see if indeed it did improve the overall comfort of the patient. So something we have to consider. Is assist control ventilation better than other modes? Is it the primary mode you should use? I mean, we get this talk all the time. That's why I really don't want to go into vent strategies and ventilator management strategies and weaning strategies, because if you ask 20 different physicians what they want to use for ventilation and what their strategy is, you're going to get 20 different answers. And the thing is, they're going to probably find 20 different studies to support their own individual answer. So we don't want to get into that. The thing we want to get into is if we're going to consider using a strategy, that it fits our particular patient. We don't want to have one strategy that we use every single time for every single patient that's not productive, that's not good to the patient. We have to individualize our ventilation. So these are the things I want you to be looking at. Number one, are they more comfortable? Number two, if you're going to assist control ventilation, you have to consider, is this patient getting ready to wean off the vent? Are they getting better and they're ready to wean? Because assist control ventilation is not going to be a very good mode to choose if you're trying to wean your patient off ventilation, because we're controlling way too much. We're not allowing the patient to work. If they're not working, their diaphragm doesn't get stronger, thus they don't do as well during the weaning part. And oh my goodness, we've come to this screen, which, as you know, means we're already at the end of the second episode. And you're like, oh, you got to be kidding me. This isn't even 10 minutes. I'm getting so excited, so enthralled. And now at this moment, this cliffhanger, you're going to cut us off. That's right. I'm cutting you off. You have to wait till the next one's released. Depending on when you watch this, maybe it's released already and then you can just jump right to episode 3. The reason why I'm cutting it off here is because we're going to start talking about a new mode of, or a different mode of ventilation next, and I don't want to rush it. So just so you know, in episode 3, we're going to start talking about volume control, and pressure control, and possibly PRVC. So those are coming, all right? Once again, I encourage you, visit our websites. www.10ceu.ning.com is our social media platform where you can read our blogs. You can take part in discussion forums that we have opened up. Or if you want to take a course, you can go to www.10ceu.com, take one of our CEU courses. It's $10 for every one CEU. $10 course, that's the name, $10 CEU. Again, we try to provide as much free content as possible for you on all of our social platforms, through the YouTube videos, through the Ning website up above. These are the things we're trying to create so you get all the free material you possibly can handle. The only thing you'll ever have to pay for is if you decide to actually get CEUs out of it. You got to pay $10 for the CEU. It costs me money to get them approved by the ARC. And so, I need to recoup something on that. Also, if you go on the $10ceu.com or either one of those sites, you can find a place where you can sign up for our email list. And that'll make sure that you're keeping constantly aware of all the new stuff that's coming out. So, again, I hope you enjoyed this video. Look forward to talking with you more in episode 3.